It's about a poor ovarian response, which is a long-standing problem. It appears it's going to stay with us for the years to come. Unfortunately, the literature is very confusing, and many times we are forced to adapt strategies and approaches for this problem that are not adequately supported and contribute to the increase of the confusion. We will try to, in the next minutes, to summarize the published literature and hopefully clear somewhat the situation. So what is poor ovarian response is the first question, which is not very easy to answer, or perhaps it's very easy to answer, but we give different answers to this question. So many of us in this room, perhaps each one of us, can give a different definition of what constitutes a poor ovarian response. To solve this problem, a conference was carried out last year in Bologna, and a manuscript was produced out of it, trying to define what is a poor ovarian response, and according to that definition, we need to fulfill 2 out of 3 criteria in order for a poor ovarian response to be present. And these are advanced maternal age, a previous poor ovarian response with less or equal to 3 oocytes in a conventional stimulation protocol, or an abnormal ovarian reserve test, either AFC or AMH. So if 2 out of these 3 criteria are fulfilled, the patient may be characterized as a poor responder. It's not a perfect definition. A lot of us can argue on this criteria, but certainly it's a starting point from which we can build knowledge that can lead to more solid conclusions. So the management of poor responders has been attempted with various methods in retrospective, prospective studies, using comparative and unfortunately non-comparative designs. Most studies, however, are underpowered and single, so they have not been repeated. And this means that useful conclusions are very difficult to be drawn. There is no doubt that there is a need for an evidence-based approach in the problem of poor responders. For this reason, we have performed 2 systematic review and meta-analyses published in 2009 and 2011 in ESHRE, trying to clear the dust. A lot of interventions have been attempted so far, such as the addition of growth hormone or GH releasing factor, addition of pyridostigmine, of aspirin, of L-arginine. GnRH antagonist protocols have been compared to agonist protocols, to no pituitary suppression, to the natural cycle. Modifications of ovarian stimulation have been performed. ESHRE has been used in all poor responders in an attempt to improve the results, as well as modifications in the duration of in vitro culture. Androgen and non-androgen modulating agents have been used. So pretreatment with transdermal testosterone has been attempted, pretreatment with DHEA, addition of aromatase inhibitors, addition of recombinant LH, and addition of ACG during ovarian stimulation. So we'll go one by one to these interventions and try to see what can be supported and what cannot. So we know that growth hormone enhances the gonadotrophic effect on granulosa cells. On the other hand, GHRF, the releasing factor of GH, enhances the gonadotrophin-induced steroidogenesis and cyclic adenosine monophosphate formation. The data on GH suggests that the addition of GH to FSH treatment results in a significant increase in live birth rate, approximately plus 17%. Now, this is an impressive difference for such a big problem, but one has to be careful because the total number of patients in this 5 studies summarized in this meta-analysis in 2009 only include a few patients, about 150. I think before adapting GH in the clinical practice based on this impressive effect, one should wait for the studies which are currently being performed, large RCTs, that are going to be completed very soon, and I think that they will definitely show if this result is close to the truth, is an accurate approximation of the truth or not. On the other hand, the addition of GHRF, the releasing factor, has been attempted in only one study. Addition of GHRF was compared to no addition. The live birth rate was 5 versus 4%. So currently, 2012, the GH addition appears to have a beneficial effect on the probability of live birth in poor responders. On the other hand, GHRF, no beneficial effect in this population. Addition of pyridostigmine. This is an acetylcholinesterase inhibitor which increases GH secretion by enhancing the action of acetylcholine. The relevant study is by Kim, that's years ago, in 1999, 70 patients. Ovarian stimulation was performed in that study with agonists and gonadotrophins. Definition of poor ovarian response, less than 3 oocytes, or a minimum requirement of 50 ampules of FSH in a previous failed IVF attempt, and the outcome of interest was ongoing pregnancy delivery rate. In that study, addition of pyridostigmine versus no addition, ongoing pregnancy rates 8.6 versus 22. No significant difference, certainly not in favor of pyridostigmine. So addition of pyridostigmine does not appear to improve ongoing pregnancy delivery rates in poor responders undergoing IVF. Aspirin. So the beneficial effect of aspirin has been shown in patients with low uterine blood flow who undergo an thawed embryo transfer, and also in oocyte donation recipients with a thin endometrium. There are some studies to suggest that aspirin might be of interest to explore. The target of aspirin in this case appears to be an impaired ovarian blood flow. The relevant study is a single study again, it's by Locke in 2004, only 60 patients, ovarian stimulation with GnRH agonist and HMG, a different definition of poor ovarian response, outcome, clinical pregnancy rate. So addition of aspirin versus placebo, clinical pregnancy rate 3 versus 6. Difference is not significant, and thus the addition of low-dose aspirin in poor responders cannot be currently supported. L-arginine is involved in the formation of nitric oxide, either by a calcium-dependent or a cytokine-inducing NO synthetase. Nitric oxide is an intra- and intercellular modulator that plays a role in follicular maturation and ovulation. This is the background based on which the authors of the study by Battaglia designed this intervention. 34 patients, a flare-up agonist protocol and the pure FSH were used for stimulation. Again, a different definition of poor ovarian response, outcome, oocytes, and pregnancy rate. So addition of L-arginine versus placebo, number of oocytes was increased with the addition of L-arginine the difference was 2.5 from 1.6 to 4.1, but pregnancy rates were not significantly different. And this is very interesting now to look at this impressive difference. 17 versus 0, still not significant. It just highlights how small studies cannot lead to solid conclusions. So this might mean that there is a difference there, and this substance needs to be further explored for the benefit of these poor patients, but also that this finding might be just a chance finding. Strictly speaking, addition of L-arginine in poor responders, although it results in increasing the number of oocytes retrieved, cannot be currently supported that it has a beneficial effect on pregnancy rate. Certainly, it is a medication to be explored in further trials. Modification of the long agonist protocol. Some colleagues have used different dosages of the GnRH agonist or different protocols for agonist administration. Two studies, Dirnfeld 99 and Garcia Velasco in 2000, approximately the same small sample size, 63 and 70 patients. In the study by Dirnfeld, a standard long luteal protocol was compared with a stop agonist long protocol, and the same was true for the study of Garcia Velasco. The stop agonist protocol was defined as administration of agonist initiated in mid-luteal and stopped upon adequate downregulation, and stopped with the onset of menses in the study by Garcia Velasco. Definition of poor ovarian response, of course, it's different in the two studies. The outcome was ongoing pregnancy rates. So in the study by Dirnfeld, 5 versus 2.6%, no significant difference. In the study by Garcia Velasco, 13.9 versus 17.6, again small, non-significant difference. So the use of the stop agonist protocol described as above does not appear to enhance the probability of pregnancy over the conventional long agonist protocol. Some colleagues have compared the short versus the long protocol. The short protocol, the short agonist protocol, we know that it promotes follicular growth by taking advantage of the flare-up effect of agonists on pituitary gonadotrophin release. On the other hand, the long protocol is theoretically resulting in a more coordinated follicular growth. Relevant studies by R.L. Weissman in 2003, 60 patients. Short protocol was a high dose of agonist for 4 days, followed by a standard agonist dose, and the long protocol was on the other side. Definition of poor ovarian response, less than 5 oocytes, etc., etc. Clinical pregnancy rate, short versus long, 3 versus 22.6. Another puzzling difference. The p-level in this study is 0.053, very close to significance. Confidence interval includes 0, so the difference is not significant. So either there is a difference in favor of the long protocol, contrary to what most of us believe, or again, it's a chance finding. Short and long agonist protocols, strictly speaking, did not yield significantly different results in poor responders undergoing IVF until today. GnRH antagonist versus agonist. We know that antagonists are administered during the stage of follicular recruitment, and thus suppression of endogenous gonadotrophins is not present, on the contrary to agonists, which of course suppress the selection. The relevant studies, and there are a few, were summarized by George Grisinger in 2006, 575 patients, 2 studies long agonist, 6 studies flare-up protocol, and this is the agonist study, the agonist side, and the antagonist side was on the other comparator. Definition of poor ovarian response, again varied between studies. The outcome, clinical pregnancy rate and number of oocytes. This is pregnancy rate, and as we can see, the odds ratio includes unity, so the difference is not significant in favor of the antagonist, which means that, of course, you cannot transform a poor responder to a normal responder because you administer a different type of analog, but certainly, considering all the advantages associated with antagonist usage, you may lessen the burden as Richard Fleming described earlier. The number of oocytes between the agonist and the antagonist protocol, again, was not different in this meta-analysis of studies between agonists and antagonists. So currently, no difference in pregnancy rates appears to exist between agonists and antagonists in poor responder patients. Antagonists have also been compared to no pituitary suppression. the relevant studies by Ackman in 2000, antagonist FSH-HMG versus just FSH-HMG. An interesting definition of poor ovarian response, and outcome ongoing pregnancy rate. So the antagonists versus no pituitary suppression, 20 versus 6. The difference is not significant since the rate difference includes 0. Again, an impressive difference, perhaps chance finding or a true finding. We cannot tell based on the sample size of this single study, as unfortunately is the case with most of the interventions attempted in poor responders. So currently, the addition of antagonists to ovarian stimulation does not appear to enhance significantly the probability of pregnancy in poor responders undergoing IVF and having no downregulation. Short agonists versus the natural cycle. The use of the natural cycle in poor responders as an alternative to ovarian stimulation has been described as, and is indeed, less invasive and less costly. Relevant studies by Morgia is 129 patients. A natural cycle was compared to a short agonist protocol. Definition of poor ovarian response, less than 3 oocytes, or cancellation, and outcome pregnancy rates. So the natural versus the short agonist, exactly the same pregnancy rates, 6.1 versus 6.9. No significant difference in pregnancy rates between natural cycle and short agonist protocol in poor responders undergoing IVF. Modifications of ovarian stimulation have also been attempted. Some of them have been described in the previous lecture. High versus standard dose of FSH. This is very popular. We always believe that increasing the dose, we are doing good to our patients. And also a high versus a decremental dose of FSH have been tried in poor responders. Relevant study, Cedrin-Durnerin and Klinkert, 96 patients. A high dose of 450 was compared versus a decremental dose 300 to 150 in the one study. In the study by Klinkert, a higher dose 300 was compared to a standard, let's say, dose of 150. In both studies, agonist was used. Sure, this is a long agonist and this is a mini-dose agonist protocol. Not to mention, definition of ovarian response surprisingly different between studies. So decremental versus high fixed dose, no difference in pregnancy rates, 6 versus 8. Low versus high dose, no difference. In fact, it was somewhat lower when we increase the FSH dose. So these popular beliefs that we have, some of our popular beliefs, unfortunately are not always evidence-based. So a high fixed dose gonadotrophin regimen does not improve the probability of pregnancy in poor responders. Now, there is a very interesting concept which is to initiate the FSH during the luteal phase. The theory is that the antral follicles are present in the late follicular phase of the ovarian cycle, and initiation of the further development occurs under the action of the premenstrual FSH rise. So earlier administration of FSH might increase the number of recruited follicles by, in a way, opening the recruitment window in the late luteal phase of the preceding cycle. This was the hypothesis evaluated by Luc Rombouts in 1998 in 40 patients. So that what they did, they initiated FSH during the luteal phase. Definition of poor ovarian response, 3 to 6 oocytes in the last FSH stimulated cycle. There was no pregnancy rate in the outcomes, was only COCs. The number of oocytes retrieved, initiation in the luteal phase versus standard, median was 4.5 in the one arm and 6 in the other. So no benefit from this interesting, I would say, idea. So the administration of FSH in the luteal phase has no beneficial effect on the total number of oocytes retrieved in poor responders based on the currently available data. ESHRE Available evidence is not able to demonstrate whether ESHRE is more efficacious than conventional IVF in this population, so some colleagues thought that we should do ESHRE for these patients, and this perhaps might increase the chance of pregnancy. Moreno, 98, 100 patients, long agonist HMG, fertilization method ESHRE or IVF, definition of poor ovarian response less than 6 oocytes. ESHRE versus IVF, pregnancy rate 17 versus 21, no difference really. So pregnancy rates in poor responders certainly are not dependent on the fertilization method. Day 2 versus day 3 embryo transfer. Now, there were some concerns regarding the impact of, and there are still some concerns regarding the impact of in vitro culture conditions to the limited, unfortunately, number of developing embryos in these patients. And for this reason, it has been proposed that shortening the duration of embryo culture might be associated with an improvement in pregnancy rates by increasing the number of embryos available for selection, or let's say the truth, for transfer. The relevant studies by Ptωχή in 2006, 281 patients. This is a relatively large study for such patients. Long or short, agonist protocol were used together with recombinant FSH. Definition of poor ovarian response less than 5 follicles, more than 13 millimeters. And in that study, ongoing pregnancy rates were 27 versus 16, so the rate difference was 11%, and the confidence interval did not include 0, so the difference was significant. So it was not attributed to chance. At the same time, the number of embryos between the day 2 and the day 3 group were 2 and 1.7, again a small significant difference. So it appears that shortening the duration of embryo culture in these patients is associated with an improvement in pregnancy rates, probably by increasing the number of embryos available for transfer. Now, use of androgens, this is more popular nowadays, so androgen or androgen modulating agents for poor responders. In theory, we know that accumulation of androgens in the macromillia of the primate ovary plays a critical role in early follicular development and granulosa cell proliferation. The androgen excess has been shown to stimulate early stages of follicular growth and also to increase the number of preantral and antral follicles. So the increase in intraovarian concentration of androgens might lead to an increased FSH receptor expression in granulosa cells, which in turn might lead to an increased responsiveness of the ovaries to FSH. This is the theory. Now, let's come to clinical practice. This is the meta-analysis by Bozdu we published last year. Addition of transdermal testosterone, only 2 RCTs, difference 50% by such intervention, and the difference appears to be significant. The same is true for these studies regarding live birth rate, which appears to be increased by using transdermal testosterone to 11%. On the other hand, one should be careful. There are only 2 studies, small number of patients. This is our own meta-analysis, but I would not rush into adapting transdermal testosterone for these patients. It is, nevertheless, a very interesting result that needs to be further explored. Duration of ovarian stimulation with the addition of transdermal testosterone, the weighted mean difference was also decreased, and the total dose of gonadotrophins required were also decreased with the addition of transdermal testosterone. On the other hand, the number of oocytes was increased. So it seems that there is a biological plausibility behind this impressive, again, increase in the probability of pregnancy by using transdermal testosterone. So transdermal testosterone, based on this meta-analysis, only 2 studies, in poor responders undergoing ovarian stimulation for IVF is associated with reduced duration of gonadotrophin stimulation, reduced total dose of gonadotrophins required, an increase in the number of cumulus oocyte complexes retrieved, and an increase in both the probability of clinical pregnancy and of live birth by 15 and 11% respectively. DHEA pretreatment, again a popular intervention, but there is only one relevant study, and this is by Weiser in 2010. It's not an ideally designed study, but we extracted what we could extract from that study, and what is the message is that the difference, although in favor of the DHEA, is not significant. The confidence interval of the clinical pregnancy rate includes 0, the live birth the same, so again in favor of this intervention, but the confidence interval includes 0. Number of cumulus oocyte complexes retrieved, 1 less with the DHEA, again non-significant difference, so it's not clear why even this trend, if we recognize such a thing, in these results is present. So currently, DHEA cannot, currently available evidence cannot support the use of DHEA for pretreatment of poor responders with the aim to increase the probability of clinical pregnancy, of live birth rate, or the number of oocytes retrieved. Use of aromatase inhibitors, their use has been examined in 2 RCTs, Kashyap and Osman. These were meta-analyzed by Bosdu in 2011. The difference is 8%, but it's not significant. So the use of aromatase inhibitors does not appear to increase the probability of pregnancy. At the same time, their use does result in a decrease in the total dose of gonadotrophins, although the number of oocytes are not different. Summarizing, for aromatase inhibitors in poor responders, clinical pregnancy rates, the dose of gonadotrophins, and the number of COCs are not associated with the addition of aromatase inhibitors. Recombinant LH addition, now this makes sense to a lot of us. When the relevant randomized controlled trials were meta-analyzed, studies examining the addition of recombinant LH in poor responders as outcome having the clinical pregnancy rate, the difference was not significant. It was 6% favoring LH addition, but the difference is not significant. We're talking about 600 patients, might be an insufficient sample size to draw solid conclusions, might be interesting still to test this idea, but currently you cannot say to our patients that I will give you recombinant LH because based on the published literature, this will increase your chance of pregnancy. This is not true. Recombinant LH addition, total dose of FSH required was not different. The duration of stimulation was not different between addition or not addition of recombinant LH, and the same was true for the number of oocytes retrieved. So no signs of biological plausibility behind this recombinant LH addition. Conclusions: a statistically significant association between recombinant LH addition and achievement of clinical pregnancy in poor responders cannot be currently confirmed. The same is true for the duration of stimulation, the total dose of gonadotrophins, and the number of oocytes retrieved. ACG addition has also been attempted, single study, Berkanoglu, 2007, 100 patients, clinical pregnancy rate 5% less with ACG, no difference. Total dose of gonadotrophins and duration of stimulation were, of course, reduced as one should expect by replacing ACG with FSH with ACG. Conclusions regarding ACG addition: the total dose of gonadotrophins required for ovarian stimulation and the duration were decreased, but clinical pregnancy rates were not significantly different with ACG addition. Dear colleagues, the management of poor responders still represents a challenge for the clinician, which is unfortunately further complicated, as we have seen in the last minutes, by the variations in the definition of poor ovarian response. With the exception of GH co-administration, the addition of transdermal testosterone and the shortening of the duration of embryo culture, none of the examined approaches currently appears to be beneficial. Now, due to the low incidence of poor ovarian response, the evaluation of the interventions proposed is usually performed in single underpowered studies, which, and this has to be noted, might not allow the detection of a true effect of an intervention. Thank you very much for your attention.